Good evening, everyone. It's a real pleasure to welcome you to the first session in our BNMS and Society of Radiographers joint multidisciplinary reporting webinar series. As president of the BNMS, I'm proud to see our multi-professional team contributing to this webinar. This series reflects the strength of our community, diverse in expertise but aligned in purpose. We are here to explore competencies, reviewing learning events, by sharing practical case studies. Thank you to all our speakers for their generosity and insight, to our sponsors Siemens Healthineers and Novartis for their support, and to all of you joining us this evening. I'm grateful to my co-chair Hannah Chandler for organizing and co-chairing this evening session. Hannah is one of a member of the team of Nuclear Medicine Practice Educator team for London, based at UCLH for London Imaging Academy. She's also working clinically as a nuclear medicine reporting radiographer at London Northwest University Healthcare NHS Trust, and academically as a senior lecturer on the MSc Nuclear Medicine program at University of West England. Hannah has strong passion for education, and she is our BNMS co-lead, educational co-lead and poster chair within Scientific and Educational Committee. We also have a panelist tonight, Dr. Amy Eccles, who is our BNMS honorary secretary. Amy has graduated in medicine in Cambridge, University of Cambridge, gaining distinction in both medicine and surgery, and undertook her radiology training in London at Imperial College. Amy is a radionuclide radiologist, but she's also pioneering pathways to actually provide molecular radiotherapy by radionuclide radiologists, and she's been trained and developed her therapy expertise at Guy's and St. Thomas's NHS Foundation Trust. Hannah is going to introduce our esteemed speakers tonight, and we'll start from there. Please, Hannah, to you now.
Thank you, Sabina. So thank you everybody for joining this webinar tonight, and I want to say a massive thank you to our three incredible speakers today. We have Rose Hazel Evans, who is a consultant radiographer in nuclear medicine at the West Suffolk NHS Foundation Trust, and she is the second nuclear medicine consultant in the UK, which is incredible to have here today. And she's also an MPhil student at the University of Cambridge. So thank you so much, Rose, for being here today. We've also got Amy Bishop and Sarah Stace, who both work at the Bush Hospital in Wales, and we have Sarah Stace, who is the superintendent there, and Amy Bishop, who is a nuclear medicine radiographer there, both with experience in reporting, and they're both incredibly passionate about this project and the webinar series tonight. So thank you so much for being here. You need to give yourself a big round of applause for that. So we'll get started, and we'll come back to you at the end of the presentations with a series of questions. So if you are watching this and you have any burning questions, please do pop them in the chat for Rose, Amy and Sarah, and Dr. Amy Eccles as well at the end to answer. So we'll get started with Rose's presentation, followed by Sarah and Amy's.
Hi, my name's Rose. I'll be looking at the differences between clinical and technical reporting. I have no financial interests or relationships to disclose with regard to the subject matter of this presentation. So what is a technical report? A technical report is an objective description of the scan's findings. It tells us what's there, not why it's there, or what it might mean for the patient. For example, we might say there's increased tracer uptake in the right femur. That's a technically accurate statement. It describes what we're seeing without any assumptions or clinical context. This kind of reporting is an important foundation. On its own, it's limited. It doesn't tell the referrer what the uptake is due to, and there's no interpretation or differential. So that's where a clinical reporting comes in. In contrast to technical reporting, clinical reporting is interpretive. It takes what we see on the scan and it places it within the context of the patient's history, symptoms, and any other relevant imaging and non-imaging findings. So here's an example of clinical reporting. Rather than simply stating focal increased uptake within the left sixth rib, the report goes further. It integrates the CT findings, the patient's clinical history of recent traumas, and rules out malignancy. This interpretation shows the referrer clarity, it avoids unnecessary escalation, and it shows that the uptake is benign. So this is the value of clinical reporting. It's not just stating what's on the image, but explaining what it means for the patient. So why does the distinction between clinical reporting and technical actually matter? Firstly, it's about diagnostic clarity. A purely technical report might describe what's seen on the scan, for example, increased uptake in the spine, but without clinical interpretation. Secondly, it's essential for communication with referrers. Clinicians often rely on our reports to help guide decision making. A technical-only report may raise more questions than answers, whereas a clinically interpreted report can add reassurance or urgency, depending on the findings. This distinction impacts patient management. A well-interpreted report can avoid unnecessary follow-up scans, support timely treatment, and even avoid misdiagnosis. The more useful our reports are clinically, the more value we're adding to the patient's care pathway. In the majority of cases, technical findings must be contextualised for clinical use. This can be illustrated in some bone scans, which I'll be discussing later on in the talk. So when we interpret a scan, we're not just analysing the images, we're drawing together multiple strands of clinical information to understand what the findings actually represent. Several key factors influence our interpretation, some are listed here. Age plays a major role. Some uptake patterns can suggest different things depending on patient's age. In older adults, insufficiency fractures and degenerative change is more likely. People see some degenerative change on that scan there. History of malignancy. This shifts the diagnosis significantly. The type of malignancy is also useful when thinking about pre-test probability and normal disease distribution. This is not to be relied upon, but it does help aid interpretation. Trauma, even minor trauma, can produce increased uptake, particularly in weight-bearing joints. A recent fall or surgery should always be considered when interpreting focal abnormalities. Comorbidities, conditions like osteoporosis or inflammatory arthritis, can alter the uptake pattern and the interpretation of tracer uptake. Ultimately, without this type of clinical context, even a technically accurate report may be clinically unhelpful or misleading. So this is why clinical reporting requires a holistic approach, one that integrates history, imaging, and clinical reasoning. That being said, technical reporting still has a defined and valuable role within nuclear medicine. For example, in processing and protocol documentation, technical reports are useful for recording key scan features such as tracer dose, timings, acquisition parameters, and basic findings. This ensures consistency and traceability. They're also helpful in follow-up comparisons. A technical description such as no significant change in tracer distribution when compared to the previous study can provide a baseline for clinical interpretation. In multi-centre trials or audits, where objective, consistent descriptions are needed, technical reports are often required to reduce bias. And sometimes in normal scans, when the clinical question is ruled out, a concise technical report may be sufficient, as long as the clinical context is straightforward and no abnormalities are seen. Now, thinking about what referrers actually want from a report, first and foremost, they're looking for a clear answer to the clinical question. They've hopefully referred the patient for a reason, and they need to know whether that helps confirm or rule out their concern. Our report needs to speak directly to that. If the findings are ambiguous or definitive, that's of course okay, but it's important to think about what's likely, what else should they consider, and this gives them something to work with. Referrers value recommendations or next steps. This could be suggesting further imaging or simply stating that the findings are benign and no further action is required. The goal is to make the report useful and not just accurate. If it helps the clinician make a timely, informed decision, then we've done our job well. MDTs are increasingly reliant on clinical input from imaging, and a purely technical report often falls short of what's needed. Providing a clinically interpreted report shows we understand the patient and not just the scan, and this goes to support patient-centred care. So clarity, guidance, and context. So I'm going to discuss these concepts by looking at a few case studies. Amy and Sarah will have a lot more later on, so this will just be a couple. So we've got case study 1. As you can see, there's that focal tracer uptake within the sternum there. There's also some intermediate uptake within the spine. So clinical context, this patient is over 60, has kyphoscoliosis and known breast cancer. So from this information, the scan is indeterminate. The differential includes a metastasis, and in breast cancer, the sternum would be a relatively common site, and a fracture. A limited CT was advised to characterise. So a month later, this CT was performed, and you can see the non-united fracture with some evidence of healing. So in the context of spinal work, kyphoscoliosis, e.g. that increased sternal mechanical stresses. This is likely a stress fracture, and importantly, no evidence of metastasis. We've got case study 2. Another bone scan. I think we can all agree this one is not difficult in the slightest. So technically, we have multiple foci of increased tracer uptake. The clinical information is not surprising given the scan. This patient has known prostate cancer, a PSA of over 5,000, alkaline phosphatase of 752, and they've got unexplained weight loss, which is all clinically concerning. So interpretation is multiple osteoblastic bone metastases. This is case study 3. And we're comparing the two scans here. We've got scan A and scan B. Both of them have multiple areas of increased tracer uptake, so that's factually correct. And we're comparing the most recent scan B to scan A. There are new areas of increased tracer uptake, so new lesions highlighted there. So you might be thinking disease progression. Then we look at the clinical history, and the patient's currently being treated. And it's important to remember flare phenomenon. This is a temporary increase in the radiotracer uptake or appearance of new lesions following the initiation of effective therapy. This can mimic disease progression, but it actually indicates a healing response due to increased osteoblastic activity. It typically occurs within 2 weeks to 3 months after starting therapy, and recognising this phenomenon is crucial to avoid misinterpreting it as disease progression. This can lead to unnecessary changes in treatment. It can be seen rarely as late as 6 months after treatment, so bone scintigraphy at 6 months or more should be the rule. And if there is a subsequent decrease in uptake in these lesions and no new lesions seen on the repeat exam, then it likely represents flare phenomenon. If there's a continued increase in the number and intensity of lesions beyond 6 months, then it's indicative of disease progression. So here we have scan C, which was taken 6 months after scan B, and it shows marked improvement. I think we can all agree. And so this is highlighting the importance of knowing treatment history. Case study 4. In general, case studies like CCAT are where technical reports are most used. Although the reports are interpreted, they follow well-established normal ranges taken from published data. So here we have 11% of bile salts were reabsorbed. This is in keeping with mild bile salt malabsorption. This is one of the few considerations for the requirement for a clinical report in CCAT is if the patient's on medication that can impact the study and it can't be stopped, as then the report may need to be qualified. So we've got case study 5. On the bone scan we can see increased focal uptake within the left posterior rib and increased uptake within T12 and L1. So on reviewing the clinical information, this is a scan of a 79-year-old man with a PSA of 6.8 and a Gleason score of 7. The patient was a poor historian, so no history of trauma was recorded. The planar scan was reviewed while the patient was on the scanner and it was deemed indeterminate. Thus a SPECT CT was performed to further characterise the uptake and provide a diagnosis. As you can see on the CT, the increased uptake within T12 and L1 correspond to compression fractures, and that focal uptake within the left 11th posterior rib is also corresponding to a fracture on CT. So we've got no evidence of bone metastases. So final case study 6. Reviewing this image, we have a focal area of increased tracer uptake within the left 6th rib anteriorly. At the pre-test probability, you see that there, so the patient has prostate cancer, and the pre-test probability of a solitary bone metastases in prostate cancer is very low. This is well documented in literature, and a general most likely cause of uptake in this area would be of benign origin such as costochondritis. Looking at the clinical history, he is 65, so he is reasonably young. He has a PSA in double digits, which is rising, which is clinically worrying in itself. During the report, a recent CT was reviewed. The CT was reported with no evidence of bone metastasis. However, as you can see here, there is that corresponding area of sclerosis. So this CT was then reviewed by one of our MSK radiologists, who felt that it was suspicious for a bone metastasis, so an addendum was added to the CT report. The patient, this was a while ago, the patient's since been imaged again, and they've now got multiple bone metastases throughout their skeleton. So the importance of this case study is pre-test probability is useful, but it isn't absolute, and it can lull us into a false sense of security. For reporting clinically, a knowledge of disease distribution and processes is vital, but it's important to utilise all available information. The probability is low, it doesn't mean it's non-existent. So already covered, this slide highlights some of the key pitfalls of technical-only reporting and why we need to move beyond just describing what we see. So we're not just reporting for accuracy, we're reporting to support safe, effective patient care. To just summarise the key differences, both are factually correct, but the second provides context. Thank you very much for listening. We'll be answering questions after Sarah and Amy's talk. Thank you. Bye.
Hello, we are radiographers from Withybush Hospital in West Wales, where radiographer reporting in nuclear medicine has been established since 2010. I'm a reporter and Amy oversees our Learning from Events and Excellence programme within the department. Our experience is, whether or not you report, image evaluation skills are key to ensuring high quality practice in nuclear medicine.
Rose has covered some of the technicalities to reporting. Myself and Sarah are going to show you some cases together. We have aimed to target this presentation for any operator who works in nuclear medicine, not solely reporting practitioners. A number of cases will focus on how the operator's role can have an impact on the final report. Therefore, the purpose of this presentation is to improve confidence and accuracy in nuclear medicine reporting through practice case studies, error review and competency insights. We have no disclosures.
Some of you may have heard me say this at BNMS before. I don't think that reporting is necessarily for everyone, but I do think the whole team needs to think like a reporter. The report is sometimes the only thing that the referrer sees, but the quality is only as good as the sum of all the decisions made by the team. Right at the start of the process, when a request form is received, take time to gather and document all the information available and protocol accurately. For example, don't just say elevated alkaline phosphatase. How elevated? Is it just above normal range or sky high? Look up the value and record on the request form. Note dates of relevant scans. The initial approach to the patient is so important. A rapid professional rapport and skilled history taking will often yield crucial additional information. Remember that referrers are busy people who may only write what they want to get the test. An orthopaedic referrer querying loosening of a knee replacement may omit recent history of chemotherapy. If the patient discloses any clinical information that may be useful to the person doing the scan, or the processing, or the reporting, write it on the request. Skillful patient positioning improves diagnostic confidence. While putting a patient on the scanner, watch the P-scope. For example, you'll see if a catheter is obstructing the view of a femur, and you can correct it before you start the image. Remember that for a bone scan, we need the patient in the anatomical position, just as you do for an X-ray. It is so much easier to assess and report degenerative changes in the joints then. Aim for legs internally rotated and feet immobilised with the patella centralised over the femurs. Ensure that the arms are symmetrically supported and not obscuring the thorax, with the head straight to best visualise the facet joints in the neck. Use foam pads if needed. If you can't get the patient into the optimal position, document on the request form to help the reporter. And while a scan is requiring, use the time to look at previous images. Consider importing relevant cross-sectional imaging for retrospective fusion. Make a decision on the next course of action as the data is requiring. The practitioner who acquires the images needs to be empowered to decide on further imaging. I always encourage my team to ask, if I was going to report this, what would I say? For example, if they notice a focus on the posterior image of a bone scan and cannot determine if it is renal or rib, then neither will the reporter, so they know to speak to the patient about possible trauma and set up for a 30-degree left posterior oblique, then review it and then consider SPECT CT. And if they plan a SPECT CT, they always process the SPECT data first, as sometimes the CT is subsequently not needed. For example, the lesion proves to be clothing contamination. And quality processing makes all the difference. Optimization of the image window and post-processing tools like masking will best demonstrate the pathology. then sense check the data before sending it to the reporter. And if you're considering establishing a non-medical reporting service, you will need to put in place an audit process. We use this audit tool from the GMC, which assesses inter-observatory agreement and the extent of ambiguity. And this is what we send to our radiologist. We populate the patient demographics and other complementary imaging, and every 20th radiography report is selected. Our radiologist issues us a report grading from 1 to 5, but more importantly gives feedback, such as this term might have been better than that. Any relevant learning outcomes are shared with the team as our learning from errors and excellence meetings.
Case 1. This is a patient with abdominal symptoms with a CT urogram showed chronic right renal obstruction. The clinical question is query obstruction and to establish the differential renal function. The CT report was checked and confirmed the right kidney shows massive hydronephrosis with atrophy of the cortical substance and non-dilatation of the right ureter, suggesting a chronic right PUJO. Contrast the appearance of the right kidney with the normal left kidney on this CT scan. The nuclear medicine referral was protocoled for a mag-free scan. The scan was processed and the results indicated 18% function in the right kidney. This was deemed to be inaccurate based off the visual assessment of the kidney uptake. On closer inspection of the right kidney region of interest, you can see counts from the liver have been included, which are impacting on the split function results by increasing those attributed to the right kidney. A recent paper noted that in a severely hydronephrotic kidney, often areas with increased counts can get included in the region of interest while performing nuclear medicine scans, which ultimately leads to an overestimation of the split renal function. In this image, the regions of interest have been redrawn, and we can see the function of the right kidney is now 9.89%, which is almost half that of the original processing. This scale hasn't projected very well, but the left kidney is peaking at approximately 350 counts compared to the right, which is between 40 and 80. I've included these graphs to give you a more complete picture prior to showing you the report. The left kidney shows a normal curve with the kidney filling and then emptying as expected, and the right kidney shows reduced tracer uptake and a non-functioning curve. This was the final report, quoting the reprocessed figures. I'll give you a few seconds to read this. You might think, is 9% pedantic? Does it make a real difference? However, clinically, in some cases, it can contribute to a different clinical outcome, as demonstrated in this table. The split function is not the only contributory factor in the patient pathway. However, it does assist with the urologist's decision-making. And from the peer-reviewed articles I have referenced on this slide, its impact can be significant.
This next case concerned a patient who had had a road traffic accident. He's a 77-year-old male, and there'd been a history of polytrauma, and there was concern raised over a possible pathological fracture of the pubic rami. The background was a slightly elevated prostate-specific antigen, or a PSA, as there's a protein in the blood that can be a marker for prostate cancer. And the multidisciplinary team review suggested a bone scan, and the clinical question was, is a bone biopsy needed? Here's the original X-ray. The best way to see pelvic fractures is to follow the pelvic ring until you see discontinuation. There is a fracture of the right superior and the right inferior pubic rami. On follow-up a few days later, the displacement was considerably worse on the right, with a suggestion of further non-displaced fractures on the left side. The patient went on to have a CT scan that demonstrated a probable sacroiliac joint fracture. Also on the CT scan, there was a right pubic rami fracture with signs of non-union and decreased bone density. You can see the excessive widening. The possibility of a lytic pathological fracture was raised. CT report recommended MRI or nuclear medicine. So here is our initial whole body image. For anyone not used to looking at these in nuclear medicine, you only see structures of the body that have been radio-labelled. In this case, we have osseous uptake. This is a functional image, basically only bone that has been made since the radiopharmaceutical injection 3 hours before will show. And remember, nuclear medicine is highly sensitive but non-specific. Anything that causes an osteoblastic response will have high focal intensity. We are presented with anterior and posterior images of the whole skeleton with 2 different window levels to optimise axial and appendicular skeletal display. Do we think this is a traumatic distribution? Are there any features of malignancy? Where is it hot? Where is it cold? Well, there are foci of increased activity at the acromioclavicular joints, glenohumeral joints, left sternoclavicular joint, metacarpophalangeal joints, lower lumbar spine, and the medial aspect of the left knee that are consistent with degenerative change. We also see focal activity at both sacroiliac joints and the pubic rami bilaterally, with a distribution pattern consistent with the known pelvic fractures. In view of the clinical question, we felt a SPECT of the pelvis would be useful. This gives cross-sectional images. We could not justify the additional dose of a SPECT CT as a diagnostic CT was available. The patient told us of intense left knee pain since the accident, and as he was osteoporotic, we decided to also refer for a knee radiograph to exclude an insufficiency fracture. There is no fracture. The focal activity at the medial aspect of the knee correlates with joint space narrowing and minor degenerative change. If you follow this joint, there is no gap here. The additional pain probably correlates to post-traumatic altered gait. So we've imported the CT and retrospectively fused it to the SPECT dataset. Coronal, sagittal and axial CT is displayed on the top row, while the same projection of the nuclear medicine data on the middle and fused data available on the bottom row. We see focal activity within both pubic rami that correlates to the known fractures, and both sacral ala, left worse than right. So I reported this as features of trauma, no metastases. However, we still haven't answered the clinical question, which is whether a biopsy is needed. I didn't feel this was in my scope of practice to answer, so I requested a radiologist review. The radiologist added an addendum to my report to advise against biopsy.
A 31-year-old female with non-metastatic breast CA, continuous nausea and vomiting. Oncology advised a gastric emptying study. She had already had a normal barium swallow performed which showed no blockage, so they were concerned for gastric emptying delay. I've included an image from the aforementioned barium swallow. Here we can see the J-shaped stomach in black. The barium swallow report confirmed that barium was flowing freely down the esophagus into the stomach and eventually emptying into the duodenal loop. Here we can see the interval anterior static gastric emptying images. On the 0-minute image, we can see the isotope within the stomach. However, at the 5 to 10-minute images, we can begin to see a focus of uptake superiorly to the stomach, which remains on all the subsequent images. On this processing attempt, the entire of the uptake was included in the region of interest, which results in a slow emptying curve and a raw T-half being indeterminate. On this processing, the original stomach region of interest was drawn and maintained throughout, excluding that superior focus of activity. This results in a normal curve. Here is the report. Normal gastric emptying, but we don't fully understand the mechanism of the uptake. But a desmoid tumour is a rare tumour that grows from fibroblasts in the connective tissue. Presumably the uptake is due to absorption of the tracer into the blood supply. For clarity, we used method A of the BNMS guidelines for gastric emptying, which was to administer 12 megabecquerels of GTPA labelled porridge. This is the patient's CT scan, which was acquired 2 months prior to the gastric emptying study, where a large soft tissue mass was evident. According to the BNMS guideline for this methodology, the normal range is 18 to 73 minutes. Drawing this region of interest incorrectly would lead to an inaccurate result, which could subsequently impact on the patient pathway with more unnecessary or incorrect tests, or even incorrect medication being prescribed for a condition the patient did not have.
This patient was osteoporotic with joint pain. There is vertically orientated linear activity at both sacral ala, with the suggestion of a transverse component. This initially looked like a classic Honda distribution of an insufficiency fracture. We decided to do SPECT-CT to confirm. So what do you think? It looks quite innocuous on the coronal and the sagittal views, but have a good look at the axial images. Remember that co-lesions are often missed as our eye fills in the gaps. Why are there no counts here when we'd expect bone? CT gives us the anatomical detail. There is focal activity at the periphery of a lytic ovoid metastatic lesion involving the whole of the sacral body. A CT slice measured 7 centimetres in diameter. We need to report this scan immediately, and we need to inform the referrer of a critical finding.
Case 5 is a 3-monthly MEGA, please. The previous MEGA scans were 58% and prior to that 56%. The previous MEGA was checked and the result was correlated against the information provided on the referral form, and the MEGA scan was approved. The patient attended for the MEGA and initial processing and image review was performed prior to the patient departure. This provided a preliminary result of 41%, which would be a dramatic drop in ejection fraction from the previous specified on the referral form. The data was reprocessed. The region of interest no longer includes counts from the left atrium, and the ejection fraction is now much more comparable to the previous scans. This slide shows both the processing attempts side by side with the images zoomed for easier comparison of the regions. It was initially surprising that the difference in this processing was so vast at 17%. It is noteworthy that both of these were processed using a semi-automatic processing method on the same system, and these results were generated by the same operator, as the discrepancy was noticed immediately. It is recommended that 2 members of staff should always process each individual study and compare the results. If there is a discrepancy, a further opinion should be considered. The data review section of the BNMS guidelines is actually to be performed prior to any clinical evaluation. It can be performed by a different operator than the one performing the clinical evaluation has a sort of QA procedure, providing that operator communicates any findings to the reporter. Part of this data review process is to ensure all counts are included from the left ventricle and no extraneous activity is included from the left atrium, right ventricle, spleen or descending aorta. The guideline does acknowledge that some overlap from the left atrium may be unavoidable. This was the final report. Any specific dates have been removed for patient anonymity. It is important to say at this point that the beats accepted compared to the beats rejected is very relevant, as this could also lead to an inaccurate result. The BNMS guidelines specify if a large number of rejected beats are detected, with large being more than 20%, the study should be repeated. The repeat should be performed when the patient's heart rate is settled, or you could widen the R-to-R interval tolerance for those with arrhythmias. As specified in the report, the normal range agreed by the institution is more than 55%. Therefore, 41% would have put this considerably outside of normal range. This table is from the European Society of Cardio-Oncology guidelines. With an EF drop of this magnitude, the patient would need to be part of an MDT discussion to review the treatment plan. They would consider holding chemotherapy treatment, whether they need to start a cardioprotective therapy, and whether referral to cardiology is required. Follow-up imaging would also be essential. If follow-up imaging showed a recovery in the ejection fraction, the patient would then be able to resume chemotherapy with close monitoring either by echo or MEGA. Therefore, the processing of MEGA scans is essential for their pathway.
Here is another oncology referral. Anything jumping out at you? Have a look at the right side of the face. There is asymmetrical focal activity. As usual, the patient is the best source of extra clinical information. She discloses trauma. We see correlation on SPECT-CT of nuclear medicine activity at the site of a comminuted infraorbital fracture around the right maxillary sinus. The best thing to do is locate the focus on the nuclear medicine data and use this to correlate to know where to look on the CT for anatomical detail. I find it's really hard to see facial fracture lines, but look at the sinuses. On the left we have normal air-filled appearance, whereas on the right there's grey donating blood in the sinus. The key thing is we don't think that there are metastases, as now we have an explanation for the facial uptake. So we no longer have a differential diagnosis.
Case 7. This was for a patient with a unilateral tremor, strong family history of Parkinson's disease. The tremor was not suggestive of Parkinsonian tremor, however, given the family history, the referrer wanted us to do a DAT scan. The referral was authorised. These are the DAT scan axial images. We can see comma-shaped striata, which would attribute to a normal scan. DAT quant was used to provide the quantification results. The graph shows an unexpected result, with 2 standard deviations above the normal range. On inspection of the regions of interest, the background appears to be over a darker area of the occiput. This can sometimes occur if the patient has a long neck or they've been positioned further into the detector. After manually moving the background, it had this effect on the graphs. We can see the patient's results are now plotted much closer to the upper normal range. This demonstrates the importance of sense checking the process data by thinking of how it will be reported. Here is Sarah's report. The report can now use DAT-Quant to back up the visual assessment. I'll give you a bit to read this. Included within the DAT-Quant processing handbook, it asks us to consider moving our eyes, and they provide instructions on how to do this. It becomes easy to rely upon processing software or AI. At the start of an integration of a new software, you may be more sceptical, but once you've been using it for some time and you find it reliable, you may become a bit more complacent. Generally, DAT-Quant has been found to be very good at ROI placement, including in recent publications funded by non-biased sources such as the Italian Ministry for Health. Other articles have found that ROI mispositioning can occur with DAT-Quant, and it is usually the background ROIs that suffer this. Literature has also noted other DAT processing software can have the same potential shortcomings. Luckily, within DAT-Quant, we do have the means to move the ROIs. I would say personally, I manually move the ROIs on 1 patient per DAT list, or sometimes every other list, and we do 7 DATs per session.
Here's a scan of a patient post-radical prostatectomy with a rise in PSA, and the clinical question was query bone mets. I nearly missed this pathology. There were no previous bone scans for comparison, and nothing on the request form to indicate known metastases. Whilst we were doing the scan, the radiographer read through the previous imaging on PAS and found reference to a PET PSMA scan from 6 months ago at another centre. It showed avid foci at L5 and the left ilium. So we undertook a SPECT, saw subtle focal activity, so proceeded to a SPECT CT. There was correlation to the periphery of a subtle ovoid lesion at the left ilium, and correlation to further lytic lesion at L5, as seen on the PET PSMA.
Case 9. This was a patient on long-term chemotherapy for melanoma, and they wanted a mugger. There were no previous imaging available, so we assumed this was for a baseline scan. Following the discussion with the patient, it became apparent the patient had had previous muggers in a different health board. The other health board was contacted, and it transpired the ejection fraction was always over 60%, with the most recent actually being 68%, but this was 11 months ago. This differed vastly from our processing of 50% on the day. This is the previous mugger from the other health board. We can see the processing software looks very different. Luckily, we do have a link with the other health board as they provide our medical physics support. We sent over our raw data so it could be processed on the alternate software. The same data was reprocessed and provided an ejection fraction of 57%, so still a drop from the previous mugger, but not as significant. The BNMS guidelines recognises that ejection fraction analysis can vary by acquisition method and analysis technique. This report did provide some challenges, as we now had 2 different results for the same scan, but from different institutions. You can see how these challenges were navigated in this slide. As with the previous mugger, the difference in ejection fraction was still significant. more than 10%. So the previous slide's discussion regarding patient pathways is applicable. In addition, this stark difference was thought-provoking. We have a one-scanner department, so differences in acquisition method and process and software was not something I had considered before. It also made me wary for any changes to hardware or software within the department in the future, and how we will navigate these carefully for this patient cohort.
Here's a myocardial perfusion scan. For those of you who aren't used to looking at cardiacs, the top row are the stress images, so the perfusion after the heart has worked hard, and the bottom row are the rest data, where the radiopharmaceutical is given when the patient's at rest. The distribution is a representation of the perfusion at the point of administration. The short axis images are on the top, as if you sliced the heart parallel to the axis. Basically, there's no perfusion at the apex. In fact, on all three planes there's a big hole that doesn't go away. I don't report cardiacs, but our cardiologist reported this as a significant non-reversible defect and a high risk of future cardiac events. But the reason I'm showing you this case is to emphasise the value of incidental findings. We've also acquired a non-diagnostic, low-resolution CT for attenuation correction that isn't really non-diagnostic. This is the same image with different windowing. There is fluid pooling at the left lung base and lack of lung markings at the anterior section, indicating a significant hydropneumothorax. If you see this when you're processing cardiac data, you need to flag it up to the CT reporter. Our clinical technologist ensured that the CT dataset was reported and the referrer informed before the patient left the department. And is there anything jumping out at you on this last case? Well, there is some unexplained focal activity that does not appear to be in bone. We thought to take a SPECT, then we'd know if the activity was artefact or real. This located the activity to the left breast. So we fused the SPECT to the latest CT dataset for localization. It was reported as probably nothing, but breast imaging recommended. The patient didn't actually have an ultrasound, but a mammogram. On the left image is the craniocaudal view, so the X-ray beam travels from top to bottom, and on the right hand side is the medial lateral oblique, so middle out. You can see the dense implant and you can see some staples, but the images were reported as normal. So most incidental findings are just that, something and nothing. They can be the most challenging thing to report, however, as we need to balance over-referring for other tests with not missing something significant findings. In summary then, a radiographer reporting service is a realistic undertaking. You do need a good grounding in all imaging modalities, and I do feel that mentoring support is essential. But the more you learn, the more you realise there's so much more to know. But if you share your skills with your team, the images will be much easier to report. And job satisfaction can be high in being able to influence the whole imaging process and issue timely reports. And absolutely, we need a culture of learning from errors and excellence in nuclear medicine.
Here are our references. Thank you for listening.
Lovely. Thank you so much, Rose, Sarah and Amy, for those lovely talks, brilliant talks. For those of you who are watching, we have seen that there's a few questions that have popped up through the chat, so do feel free to use the Q&A button at the bottom of your screens to pop in a few more questions if you have them. But I think above all else, there is definitely one question that has come through quite a bit, so I'm going to direct this towards Rose, Sarah and Amy to start with. And that's about, could you kind of give us a bit of an idea of your pathway into reporting, you know, whether that's your qualifications or journey within your department into the reporting process. Rose, did you want to start off by sharing your journey to start with?
Yes, of course. So I think I did see a question about qualifications, which I'll just quickly answer as well. I have a degree in diagnostic radiography. I then did my master's in nuclear medicine at King's College London, and then I did a postgraduate diploma in advanced practice at UWE, which includes the reporting skills for radiographers and technologists there. And I also have a PG cert in leadership and management. So I got into reporting. I'm afraid it wasn't a very quick process. So if anyone's hoping it was fast, it wasn't particularly fast. We started the conversations whilst I was doing my master's, and I began reporting a few things here and there with my consultant radiologist mentor then. And then when we decided that this is how we were going to go for it, it was, I think it took 2 years I reported everything that came through the department, and then they were doubled reported, and we did a series of audits and go from there. I'll let Sarah go.
Rose. Sarah, did you want to share your pathway? Because I think it's a little different, isn't it?
Yeah, so I was a DCR radiographer, and when I started in nuclear medicine, within a few years I was put on the MSc course. I completed the MSc, and it was about 9 years before I did the reporting course, and then I started reporting pretty much straight away then. But I would say in those 9 years I was building up the skills, so every time I did a scan I would make a note in my book about what I thought the appearances were, and then later on when I had 5 minutes I'd check them. So I practiced reporting a long time before I actually did the course. And the reason we were able to start doing reporting in our hospital was because we had one of my colleagues was a reporter in a test probably most of you wouldn't have heard of, which is a barium enema. But because he worked in fluoroscopy and nuclear medicine and had proven himself in that modality, it was acceptable then for him to start reporting in nuclear medicine, and then he mentored me. So we started off with dual reporting and then built up competence over time then.
Brilliant. Thank you so much, Sarah and Rose, for sharing your experiences through reporting. I would say there's definitely different journeys into reporting from radiographer perspective as well as clinical technologist perspective. So it's really good to kind of see the different pathways that are coming through. Sabina, did you want to ask the next question?
I think it's quite interesting, is it? It's a long journey. It's not something that it can be learned overnight. And I think it's important for everyone to understand how much effort goes into the learning scope of the practice. So thank you for sharing that. So I think there are a lot of questions, so we'll move on the next one. Is the flare phenomenon more likely with some pathology than others? And what is the flare phenomenon? Maybe Amy Eccles might answer on that one.
I can try. Thank you. So the flare phenomenon is where you actually see increased activity in the cases that Rose showed, obviously on a bone scan, but you can also see it on a PET CT scan, particularly thinking about FDG. And it's where the lesions actually they look worse than they did maybe on the baseline scan. It's often seen within about 4 to 6 weeks of starting treatment, and we're seeing it increasingly commonly with patients who are on immunotherapy rather than maybe the standard chemotherapies. And it's probably, in my very basic brain, related to maybe increased vascularity, increased sort of metabolic activity whilst the tumours are responding to treatment. And it can be also called pseudo progression. So you need to know, as the talks have already highlighted, the importance of clinical history for these patients. So I don't think it's restricted to a particular cancer type. It can be seen in the majority of cancers, and it's not just related to immunotherapy. It can also be seen in other treatments as well. So knowing what pathology you're looking at, or why the question's been asked in the first place, the timing and the type of therapies is really important to know as well. And when you are generating a report, be aware that your words do carry weight and meaning. And I've been caught out with this personally, where I've called something progression, and then the oncologist has actually come and sought me out in the reporting room because it then meant that the pharmacy was not prepared to prescribe the next dose of chemotherapy. And he said, "Are you sure this is progression?" And I said, "Well, now you've asked that question, I'm not going to be sure. I never say never, and I never say always." The patient then went on to have another scan a little bit later down the line, so talking 2 to 3 months after initiating treatment, and actually everything was stabilized, and we were happy that this probably was a flare phenomenon from the treatment. But you just have to take what you have and the information that you've got and use the electronic patient record, ask questions if you're not sure. And whether you're a radiographer or a radiologist or a nuclear medicine physician, these are pictures. They may not give you all the answers. So you have to be aware of the limitations of the study that you are reporting. And if you're not sure, it's okay to say that. Maybe bring the discussion back to MDT, maybe recommend another short interval scan, correlation with tumour markers, etc., and be prepared to sort of sometimes suggest more things rather than give an absolute hard and fast answer.
Yeah, I think that's really good answer. Thank you, Amy. Just to mention that this scan was done 4 months after, and we tend not to scan clinically in so short period for bone scanning, particularly if we know that patient is on chemotherapy, but it does happen quite often in research setting, and therefore there are like separate research reporting criteria for like while we are scanning patients during their chemotherapy, when we need to report for 2 or more lesions if they are new, that they might be progression, specifically for bone scanning. But as Amy mentioned, nowadays with the FDG PET, we are regularly scanning with the like immunotherapy, and then we need to be aware of the pseudo progression very often. So that was really good question. Thank you for this question. So I think, Hannah, the next one for you.
Yes, absolutely. So this is going back to a couple of the case studies, I believe, from the questions here, and I've just lost them in front of me. Here we go. So somebody is asking around the protocol. That's quite interesting that you're using previous CT data to fuse with current data in nuclear medicine that you're acquiring. They just wondered kind of how often that you're doing this, and whether it's a complicated thing to try and process your kind of older CT data with your current nuclear medicine data.
I would say that we always start by looking at the CT that we have to make that decision, and under the ALARA principle about whether we can justify an additional exposure. We always consider the patient positioning and whether it would fuse with the position that we've put our patient in. And if we intend to retrospectively fuse, we may put the patient to mimic that position to start with. And we consider whether the pathology is demonstrated on the CT, because there's no point fusing a spec to show a lesion if you can't actually see that lesion on the CT, because remember, CT is an anatomical study and the changes often show up a lot later than they will on bone scan. But if you can see the lesion, like that example I showed you with the pelvic fracture, if you can see the lesion on the CT and you know what it is and you want to prove that's all it is, then it makes absolute sense not to justify another CT exposure, but to import that and fuse it to your SPECT. You do need to really be aware of your pathology, and you can always, you could inadvertently fuse something to make it look like, say, a level of T6, but it's actually a met at T5. So you really need to be very aware of your anatomy when you're fusing.
Yeah, I would also say, going away from bone scans, if we think about MPI imaging, they have their stress and rest scans quite close together. So we never CT them on the rest imaging. We only ever CT them on the stress scan, and they fuse really easily. It probably takes us less than a minute to fuse those because they're done on the same bed, generally in the same position. So I just thought I'd talk about something other than bones.
Can I follow on this question? Because it was like about what specific steps of training are needed to empower the operator acquiring the images to decide on immediate further imaging, such as SPECT-CT. I think that's quite important, because I think question was here, when your radiologist, or does your radiologist authorize additional CT exposure from SPECT-CT, or can we actually train operators to authorize that?
Okay, so we always work under delegated authorization guidelines. So if I can give you an example of our DAGs for bone scans, we have prior authorization. I'll read them out. It says, to further investigate a foci or focus of increased activity seen on bone scan where an abnormality is suspected. To further investigate joint prosthesis where there's unexplained uptake on scintigraphy. Or the proviso that we use quite often is to further investigate unexplained uptake in cases where interpretation is considered difficult or complex. So all the operators within our nuclear medicine team, and that's a mixed team of radiographers and clinical technologists, they all have in-house training and work under DAGs in order to make that decision. we couldn't possibly bother a busy radiologist every time we wanted to make that decision. So the team need to be, it's very important the team are empowered to make that decision themselves.
Yeah, we also scan into the evenings, so we don't always have radiologist support on site. So we would be impacting the patient pathway by delaying these scans. We have made a flow chart to try and help with the decision-making process, but obviously staff training is the most important aspect of this.
How long does it take to train staff, and are you happy to share your training with other departments that are interested in your protocol for the training?
I did actually present at BNMS a couple of years ago where I presented the flow chart. We have had we've had quite experienced staff over the years, but we've actually had new staff this year. So I'm hoping to trial it with them. They've been with us for about 8 months now, and I'm going to see how well it works with them, and I might redevelop it, and then I might do another presentation.
She will do another presentation.
Lovely.
Great. Lovely. Thank you so much. Now we are kind of coming to the end of this webinar, and I will just finalise it with one question that's been asked that actually links in very well with our next webinar. So somebody in the chat has asked about reporting any technical issues either during reporting or from a practical point of view that follows into the report, and whether there's any kind of guidance around that. And our next webinar, which is happening in December, on the 2nd of December at the same time, is all about realm reporting and realm in nuclear medicine, which is all about errors and complications and things like that, and reporting those. So if that is something you're interested in, the follow-up webinar in December is definitely the one for you. Now, we have only got a couple of minutes to go, so I think it's time to thank all of our speakers and panelists. So I will thank Amy Bishop, Sarah Stace, Rose Hazel Evans, Dr. Amy Eccles, and of course Sabina for being my co-chair here in this session. Thank you so much for taking the time this evening to share your experiences and answer some of the questions that have come through. I'm sure if anybody does have any follow-up questions, then they can reach out and those can be answered later on. Also need to thank our great sponsors for these webinars, which are Siemens Healthineers and Novartis. And again, to remind you about the next webinar in this particular series on multidisciplinary reporting is the implementation of realm in nuclear medicine on the 2nd of December. We also have some lovely sets of webinars coming up in the new year to celebrate the 60th year of the BNMS, which will follow some journeys of our presidents of previous years. And Sabina, did you want to close off at all and add anything to that?
Yeah, so we'll have a celebratory webinars from January to April and discussion with our past presidents looking for the future with very exciting topics. So please look for the schedule. And then our third webinar in the series of multidisciplinary reporting will be on DEXA reporting, and that's going to be in May. So we welcome you to join us and thank you for your contributions. I know there are a few questions left, but we will address them in chat box, or please reach directly to our speakers. Thank you all, and see you in December. And please, I just want to mention there is a webinar which is unfortunately not free, but it's fantastic in cardiovascular disease in women health. So look for that on 19th of November as well. Thank you. Bye. Bye for now. Have a lovely evening.
Thank you, everybody. Bye.
Thank you. Bye-bye.